Thank you everyone for joining. My name is Lindsay Miller. I'm the facilitator for today. I am an 11-year papillary thyroid cancer survivor. This is my first in-person meeting. I'm very excited to be here. I'm from Albany, New York. It's my pleasure to introduce our speaker, Dr. Erik Blomain. Dr. Blomain is a radiation oncologist at Thomas Jefferson University in Philadelphia. His focus is on translational cancer research, as well as patient-centered care, advocacy, and survivorship for cancer patients. He completed the MD PhD program and completed his medical internship at Thomas Jefferson University in Philadelphia. So thank you, Doctor, for joining us and being with us today.
Yeah, I'm happy to be here, and I'm happy to present on this timely topic. Given all the recent issues with digital health and the pandemic, I think this is a very apropos and timely talk. So yeah, I'm going to be talking about patient advocacy issues in this era today. I'll just briefly talk about my journey. So I'm a thyroid cancer survivor myself, 15 years of papillary. So I began when I was still in medical school, volunteering at ThyCa on the support phone lines in 2017. And that experience was very formative in a way, because I had experienced a totally different type of patient communication than as a doctor. Obviously, the skills of communicating with patients kind of were helpful, but it was just a totally different type of dialogue. And so I discovered in myself a passion for empowering patients and patient advocacy. So as I graduated from medical school and kind of went through residency, I was fortunate to have a fellow trainee who was a lymphoma survivor, and she had become a patient advocate for lymphoma. And so this was kind of modeled for me in a way. And then with her encouragement and the encouragement of some of my faculty at my residency at Stanford, I applied and was accepted as the NCCN Guidelines Committee patient advocate. And for those that don't know, the NCCN is a national body that creates guidelines that doctors in the community and academia follow as kind of the gold standard of cancer care. And so that's been a very kind of enlightening and informative job, and a big responsibility that I'm happy to talk to you a little bit more about today. So, but when I got picked to that role, occurred to me I probably should have a pretty crystallized definition of what patient advocacy is, because it's kind of this nebulous concept. I think we all generally have a sense of what it is, but when you actually have to sit down and put words to paper, it's not always so easy. So I Googled it. The NCI has a very technical definition that's kind of hard to read for people in the room, I'm sorry, but and then Wikipedia has one. These are primarily like a utilitarian definition about advocating for patients, for their insurance companies or for their care. But they were kind of, missing a little bit for what I experienced of it, which again, kind of grew out of this interpersonal communication model of advocacy. So I define it now after a couple of years of doing this, though admittedly still learning every day and not an expert. I define a patient advocate as someone who endeavors to ensure that the needs of patients are being met and that their unique voice and perspective are heard in matters that affect them. And so that could be something as micro scale as a doctor-patient interaction in the room, or something as macro scale as legislative advocacy, like in Congress. And the common thread through all of that, for me at least, is communication, communicating those perspectives, communicating those needs, that sort of thing. And as I said, it can be kind of at the micro level, and then at the macro level. So I'm going to kind of introduce these two levels and these different concepts, and then I'm going to get to the digital health and how that's kind of coming in like a wrecking ball in some ways to these things, and how we have to kind of be aware of the disruptive potential in the good, for the good and the bad. So this is kind of an ideal cartoon, right? You want your patient and your doctor, you want to be on the same page, you want to be communicating, you want to be getting the best outcomes. But there are barriers to that. On the patient side, there's barriers to communication, there's fear. I'm a very scared patient. The further out you get, it gets better and better. But in general, I'm a very scared patient. Struggling to understand a complex disease, financial stress, family stress, and the desire to be kind of heard and to communicate. And now that I've kind of done this on both sides, I can say the physician has barriers in their mind and their heart as well, including fear of failing the patient, struggling to teach and explain the complex disease. There's a lot of time pressures and administrative pressures that are leading to burnout. And it's a constant challenge for us to remember why we do what we do, which is our patients. And, I hold myself to a high standard with that, but it's not always easy when you have, 50 meaningless checkboxes to check to get through a visit or something like that. And then the desire to communicate on the reciprocal side of the patient. And so we'll work in like practical tips or things that I've kind of experienced when I can. So I think if you're a patient and you're new to this, I think it's important to remember it's okay to feel overwhelmed. But in terms of advocating for yourself, it's important to be as specific as you want, as you can be with what your concerns are. And that could be something as, depending on your level of kind of literacy and education in the area, something as specific as, oh, I read this treatment versus that treatment, and why are we doing it this way? Or something as fundamental as, I'm scared that my cancer is coming back, or I'm scared of the side effects of treatment. And then it's kind of on your doctor to build off of that communication to kind of get to where we need to get. But clearly communicating your needs is very important in terms of self-advocacy or for caregiver advocacy. But then always also, as you assert those things, be ready to listen and learn. And then for my colleagues, just, not that I'm preaching to anybody, but the things that have worked for me, listen and say, I don't know a lot when you don't know. I do that. I don't know a lot. Notice what is left unsaid. This is something that I'd never really had a great sense of until I was a patient. Not that other people don't also get there by their own ways, I guess, dealing with patients, but when someone asks a question, why are they asking that question? Is there a fear? Is there kind of an underlying fundamental reason for that? And being a patient has kind of helped me kind of perceive when that's the case. But I think it's important to look out for those kinds of hidden meanings and things to foster that relationship and trust. And then in a challenging situation, again, just remember what the patient's going through and always be empathetic, because, cancer care is very stressful and very labor intensive for the patients and the doctors and the hospitals. And so there are a lot of potentials for stressful situations, and, dealing with them becomes a challenge. I'm going to pivot a little bit to talk about this digital health barriers to this communication and this doctor-patient relationship I'm talking about. There's been a lot of interest recently about, even before the pandemic, about how we're pivoting to more of like a scans model of medicine or results, and kind of this lost art of medical touch. The overlying theme is loss of humanity in medicine, and I think that manifests in many ways. I've chosen to kind of show some kind of cartoons and articles, and in a minute I'll even show a TED talk about kind of the physical exam and medical touch as one example. But I think the overarching theme is that people are feeling less and less connected to their healthcare teams and more like a participant in a large economic process. We talk about patient-centered care. I like to work in some, I don't know, even if it's a little bit flippant, a little bit humor to it. Like, we talk about patient-centered care as a buzzword, but then, it manifests like this, where the patient's literally in the center, but no one's paying attention. Does that really matter? And so I'm going to try to do this technical switch to a little excerpt from a TED talk. And I know it's a little bit tacky to show a video during a talk, but this guy really kind of articulates some of the concepts I want to illustrate pretty well. And he's a professor at my alma mater for residency, Stanford. So I don't know him personally, but and this is all about the lost art of medical touch and the concepts I was just describing. That's okay. As long as the Zoom can hear it, or the room can hear it, or whatever.
Ladies and gentlemen, that is not an unusual story. Fortunately, it happens all the time. I joke, but I only half joke, that if you come to one of our hospitals missing a limb, no one will believe you till they get a CAT scan, MRI, or orthopedic consult.
It's lagging, I think, actually.
Come to one of our hospitals missing a limb, no one will believe you till they get a CAT scan, MRI, or orthopedic consult.
It's lagging, I think. Yeah, it's buffering. I hate buffering. Refresh it or something. I'm ready to bail. If it doesn't work, it's okay. I can just keep going. that. Yeah, it's okay. Yeah, exactly. Yeah. Yeah, and we'll bail on that. It's okay. You heard kind of one of the punchlines, but essentially he makes a case for that we're more and more, as we get more of these electronic medical records and more of technology and scans available and labs available, that we're treating essentially a meta patient, in a sense, would be the best way I can describe what he will go on to describe, in the sense that like you lose sight of what's actually in the room, the person there, and you get caught up in chasing labs or all and this like information overload that we all see. That's not to disparage the technology. I mean, we've made inroads in care for our patients because of those technologies in a lot of ways, but balancing that with the humanity, I think, is a big challenge. I'll just say from my experience, I experienced that more when I was an inpatient intern, inpatient resident, more of that that loss of humanism, though it does happen in the outpatient. But to some extent in the outpatient world, I'm a little more able to set my own schedule and kind of take the time I need to with my patients. But I think every doctor to some extent feels this kind of conflicting loss of humanity. There's another New York Times article about kind of the healing power of touch. I will say that there's some controversy in this. Like, I'm not, I'll get to it in a second. There's a little bit of the good old days complex about like when I was in school, like we, were real doctors and, touch the patients and listen to the patients and everything. There's certainly advantages to, increasing technologies, but I think the point isn't that, we need to be necessarily doing exams as an end result. It's more that this connection is being lost. And a lot of people think of that kind of classic view we have of a patient encounter with a physical exam, a history, clear communication, no time pressures, as being lost. And so, I think, and more, I think I've been kind of hitting on this for a couple slides now, but medicine's becoming more and more of an industry, a consumer industry specifically. So there's this risk that, there's this concept, I trained in Silicon Valley. So there's this disruption culture people talk about. A lot of tech companies say they're disrupting this market or that market or whatever. It's kind of a buzzword. But I think that if we risk losing humanism in medicine and building dissatisfaction among patients and being treated like individuals and human beings, and we risk actually kind of losing the stewardship over what happens to certain aspects of healthcare, because there already are private companies coming in trying to replace the model of, the insurance like medical construct or complex, coming in to disrupt that. So I think we ignore these kind of issues at our own peril. I think that, we all would agree that we, as the team taking care of the patients with the expertise, would probably be the best stewards of what the new system, if there is reform, would look like. But we are not guaranteed to be those stewards. So I just want to kind of add a word of caution. I will say, though, that a lot of this also kind of has a potential for paternalism, which, for those that don't know, is the medical ethics concept is we as doctors know what's best for you. So really, with a lot of this digital medicine stuff, what does the data show? Like, is it better or worse for patients? Do we know what's best? Or is this just a bunch of doctors complaining about we want the good old days back? And so I want to take a few slides to show about kind of some of the data on digital medicine. But I do want to just talk about a new issue where there's not a lot of data. Whereas now, like, there's a recent change to a lot of electronic medical records. I know our Epic functions this way and my Epic at Stanford function that way, where patients are now getting the results instantly, often before their doctors are, because if I'm in a busy clinic, I check my inbox at the end of the day, I would have seen it, but the patient gets it instantly. So there's a potential to normally I would have typed like a brief interpretation of the results and the release to the patient or something like, or if it's a scary result, say let's talk, it's going to be okay, et cetera. And now it's just like the raw data just gets ported out instantly to the patient. And so I think there's the potential. Increased access is the goal, and portability of records and things like that. You don't want to put up barriers for patients, but I think it also increases the chance for miscommunication and misinterpretation of data, with the potential for worse patient outcomes in terms of, again, like mental health and things of that nature. So I just think that's an interesting digital health concern that's arising. There's also video visits. So, video visits are controversial. I think a lot of doctors would prefer to have patients in their office doing an exam. whereas a lot would prefer the kind of streamlined video visit, especially for things just like follow-ups, like going over results and things where exam is maybe not as important. And so if you look at, this is projecting very small on my screen, but if you look at how doctors rate video visits, on the left, there's phone visits, which, you can't really do anything much over the phone except for read people results, in my opinion. But on the video visits, where you can get kind of some assessment of how the patient's doing and maybe a little bit of their average daily activities and things like that, the overwhelming nearly 90% of respondents viewed those as favorable. So we talk about this ideal of the patient in the office, but most doctors have had favorable things to say about video visits. And then specifically, if you look at specific domains, they're very useful to review, which was what I just said, to review benign or reassuring data in labs and imaging. And but they rate poorly in the ability to establish connection with a patient or family. So they're not perfect. We would all, even I think this meeting has been a good demonstration for me, at least, as I've done this meeting virtually and now I've done it in person, and I'd much prefer to do it in person. I feel like I got to know the community better. The same holds true for medicine. So, we all have had the experience where you meet someone on video and then they come in, a patient comes in for treatment or surgery or whatever modality people are using, and they're, you essentially meeting the person for the first time, even though you've already met them. So I don't think there's any big surprises here, but I think the argument is that they serve a purpose, but they're not a replacement for face-to-face contact. The ATA recommends, has recommendations for telemedicine visits versus in-person visits. They say the excellent responders are, like, in follow-up, are a good candidate for this. Also people who live far away, which I'll get to in a little bit, including which would induce like time and financial toxicity possibly to come in. But the obvious things like symptomatic patients, new patients, or kind of with more complicated disease would benefit from an in-person visit. And so those are guidelines from the ATA about thyroid cancer specifically. Are they really better for patients? So, I've been talking about the doctor side of things, but we're talking about patient advocacy, right? Turns out patients really love video visits. The overwhelming response is very positive. And I'm guessing that's primarily driven by the convenience of it, not having to drive, park, commute. Like, I'm right now in a center city, big urban office where there's no parking, or we offer free parking, but it's just logistically hard to make it happen. There's not a big lot out front, for example. And so even at Stanford, it was really hard to get down from San Francisco to the peninsula for a lot of people. So these commuting issues, especially at big academic centers, really come up where people might be kind of making a trip to see you. Patients really prefer the video visit. And then that's where that concept of paternalism comes in, because are the patients losing something medically by not having that exam? And maybe they're unaware of it. It's hard to say exactly, like, but I think this tells us that if we're like trying to maximize patient convenience and comfort, that's a good thing. If you look, the patients actually say that a lot of things are better for telemedicine. These are specific domains. The red is kind of neutral, where they don't see a difference between in-person visits and telemedicine visits. The blue is better in telemedicine, and the green are better in the office. So you can see not much in terms of from the patient perspective is better about an office visit. They say that, I guess, the quality of visit, which I guess is kind of a subjective catch-all for everything. A lot of people, I guess, did say that quality is better, and the personal connection again. So both sides of the argument are kind of saying the connection is lost by the telemedicine. But everything else tends to be rated very highly by or neutrally between the two by patients. And if you look at kind of costs and financial toxicity, that, which I mentioned on the last slide, that is definitely a factor that people strongly favor video visits and telemedicine. And someone looked at this systematically. I believe this was a VA study from Michigan, and they looked at they actually quantified the time commuting, the financials of commuting, the CO2 emissions, which I think is really cool. It's like there's an environmental angle to it. And they quantified the benefits of video visits being rolled out in the pandemic in the VA in Michigan. So I thought this was a really cool study that kind of jives with a lot of what we're talking about. And then this is just a satisfaction score from that same paper. And it's very small and hard to read. I'm sorry about that. But yeah, generally patients were very satisfied with the video visits. And so I'm going to pivot a little bit. I talked about, so that's all advocacy kind of on a smaller scale about the doctor-patient relationship. I mentioned kind of advocacy on a larger scale, policy decisions and things of that nature. I think there's multiple issues that have arisen that we can potentially learn from or discuss, both from the pandemic and this era of digital medicine, that I think are important going forward. I'm just going to kind of give a quick introduction that one of the things we're about to talk about is kind of how the shutdown was handled. And so in terms of limiting patient visitors and kind of the loneliness of cancer care and support, I'm aware that this is a very sensitive issue because a lot of people were afraid of getting sick and were immunosuppressed. So I don't think there's one right answer, but so I'm just going to kind of give that warning up front that this is kind of a sensitive area. I don't fall very strongly on one side or the other, but when in doubt, I don't think anyone should die alone in the hospital. So there were a lot of lay press articles. This one was in the Wall Street Journal about this exact phenomenon where people were forced to say goodbye to their loved ones over Zoom. This was not limited to patients with cancer. I'm not even sure this article might have actually been about a non-oncologic death, but it was certainly happening to cancer patients, even if it wasn't this particular example. And so it really brought out this advocacy issue. It's like, do we value the potential for hospital spread infections in that scenario, which we were all very afraid of at the time, and we were still learning about this whole pandemic. But at the same time, it's a very real phenomenon that patients were dying alone. And that's like one of the biggest tragedies I can imagine as a patient. And I was afraid enough getting surgery where I would go home the next day and hopefully be cured of my disease, and having to stay, by myself. So when I can only imagine the fear that those patients had to endure. And I just hope that, we can kind of split this difference between what's best for, I kind of throw the wrath of Khan, needs of the many outweigh the needs of the few, or the one. I'm also wearing Star Trek socks. That was actually not planned, but I have, I'm kind of outing myself as a science fiction fanatic, but anyway. But then this quote from an article also kind of captures some science fiction, and yeah, it kind of talks about losing our humanity while paying lip service to the needs of the many, because at the end of the day, the many is just a collection of a lot of ones. So, if we're trying to save a population, sure, population health is a very vital science and a great thing, but I think there's a chance that sometimes the one gets swept up and lost in that. And so not just, kind of in addition to that, I also advocate for kind of humanism in medicine, which is kind of supporting my patient's lived experience and these kind of emotional connections and encounters with patients. And so I advocate with things like caregiver medically necessary when even when maybe it was a little skirting the issue or a gray area for my patients when they were going through treatment during the pandemic. I voiced opposition on humanistic grounds on the visitor policy. I actually was at a ThyCa support group and someone complained about this visitor policy at my specific hospital at the time I was working there. And that was kind of one of the things that spurred me into action, actually. I think in the end, there was the inertia of safety in terms of the needs of the many largely won out. But I think, again, this is a very complicated issue. I think, history will judge us on our response, and I think unfavorably in a lot of ways, and not this, I'm just talking in general as a society, but I'm not here to preach about COVID. So I just think that this was a very hard time, and there's a lot we can try to learn from and apply to when times are better. But I would advocate in general for a humanistic kind of individualized approach to these kinds of things. And one thing we saw also, which is kind of tragic, is that a lot of patients were reluctant to get screening healthcare. They were reluctant to access their healthcare because they were afraid of infections, or the visitor policy, they were afraid to come alone. And so we've definitely seen it's thankfully leveling back off to normals now, but there was in 2021, 2022, anecdotally, and in some studies, an increase in like later stage presentations for screenable cancers. Which again is a very bad outcome if you really think about it, because you take a potentially curable situation and potentially make it not so. And So this is data that shows that patients without companions do worse than patients with companions. And so, yeah, all of these issues kind of inform what I would advocate for in terms of humanism and these kinds of things going forward. And I just checked a few of the main ones there. So lessons that we learned, I think we have to weigh public health policies against humanistic concerns. I think we have to listen empathetically and adaptively to the needs of patients as they arise, and then collect and analyze the data with scientific rigor. Because even now, I am showing some data, but a lot of this is my own opinion. So take that as a caveat. So the other thing is what requires advocacy on a larger scale, in addition to these kind of pandemic specific issues. I mentioned this disruption culture. Patients are demanding more personalized care. Like, you go any other industry, right? We were just talking about this at our session yesterday, where everyone's saying, well, can't you just load the pictures from another institution to your institution through like Care Everywhere on Epic? But it doesn't work that way. Things in medicine are not as seamless as patients have come to expect from their experience in other service industries. And so I think there's a lot of that kind of grassroots efforts to make things more personal and more self-advocacy things, like having your own records in a portable place that you can control, which I think are all great. But I challenge healthcare leadership to stay ahead of that wave, not to be the ones that are disrupted or the ones that are kind of fighting against change, but actually as active participants in making things better and more accessible for our patients. So I'd just like to conclude by kind of summarizing briefly, but I think hopefully you've taken away from this that patient advocacy involves communication of the patient perspective on multiple levels. That advances in technology have expanded the role for patient advocates to ensure that the advances are applied with kind of humanistic concerns in mind, and that the pandemic and the resulting boom in digital health created many patient advocacy issues that we need to consider carefully in guiding our future decisions. And then, yeah, I'd like to thank you all. I even, not all of these are heroes. Obviously, Walter White's not, but I always like kind of mentions of cancer in popular culture. I just find them funny. So I just throw that on there. And yeah, I'd like to thank everybody for their time, and thank my clinical department for helping me attend the meeting, the NCCN committee for having me on as their patient advocate, and a lot of people at ThyCa along the way that I've met. So thank you, and I'm happy to take any questions.
So I have a microphone here in the room if there's anyone has questions, and then we'll be taking questions from Zoom too. So we did have one participant, Katie, just agree with your statement about how hard COVID was, and having thyroid cancer surgery without her husband there was very difficult. And someone else just thanked you for a very good talk and said they were part of last year's as well.
Thank you all.
I guess I find it very refreshing to hear from you, and really just being in this ThyCa space, and the doctors that come here, I think, are similar. But what are the opportunities for doctors and physicians or requirements to do some of this training in terms of person-centered, care, and kind of having empathy and learning how to speak at the patient level?
Yeah, there's supposed to be like formal training in medical school, and I say supposed to, there is. Definitely there's things like simulated patient encounters, which are like the actor patients, if you've seen like the Seinfeld, that kind of makes fun of that. But anyway, that's real, that we learn by practice and talking to. There's ways to do it. Like there's like frameworks you can learn to they're often used for breaking bad news. That's kind of how it enters the med school curriculum, but they can be applied to kind of any difficult communication. I think I use those frameworks early on, but now for me, it's more of an organic thing where I just have internalized something that I can't even really articulate, but I can generally have the communication skills that I need to have that encounter. And then during residency, there was a formal training in this kind of thing. So it's out there, and it is to some extent required, but it is kind of hit and miss in terms of the way it's prioritized versus the million other things that have to be learned.
All right, we have some questions here on Zoom. One attendee is asking, what would you suggest a patient should do when they had a very unprofessional and rude interaction with the doctor?
Yeah, I'm sorry that happened. Yeah, I think in general, most people don't go into an encounter kind of wanting to have a bad interaction. I think, I think in that case, it's best, not to escalate things. I think, and kind of try to, I guess, see where the other person's coming from in a way. But at the end of the day, these are interpersonal relationships, and sometimes there's just not a match. So, depending on the level of, without knowing, what exactly was said or what happened, if it's, unprofessional in the extent that it was in some way, defamatory, that's like kind of beyond the pale of what I'm talking about. But if it's a more general kind of lack of consideration for your concerns, or just kind of the way that they presented the information, then that might just not be a match. And so in that case, it's okay to have a frank discussion about that with that person. Again, communication is kind of my billboard that I'll send you with. But, at the end of the day, sometimes these relationships don't work out. And then I think it's important to trust your care team. So, there's no harm in having a second opinion, or seeing if, another provider or another doctor would be better suited to kind of handle your needs.
Another question from Tony. I am 1.5 years, no evidence of disease, and find I get overwhelmed when the doctor is reviewing my labs because I'm still learning how numbers correlate. How do we get doctors to slow down in their review of patient status?
Yeah, I'm totally right. I'm 15 years out and I'm right there with you, with, some knowledge to bring to bear on the situation. Even I still feel they call it scan anxiety, but it's not really a scan. It's the labs, but it's the same kind of concept of like anxiety over your test results. I think that, it depends on how you learn, but like a lot of times showing graphs can be helpful. Like a lot of times Epic or whatever medical record they have can be used to visually depict things or kind of show it in a different way. Because if it's just like, oh, your labs are this, and that's good, you're done. Like if that's how they're kind of teaching, but you're not an auditory learner, that could be very challenging. So I think that, I think asking them to slow down, it would be a first step, but then maybe, is there any other way that you can present this concept either visually or however you happen to learn best? Generally we have those options is what I'm trying to communicate, like to present things in different ways that are meaningful to you.
Yeah, I wanted to just chime in there. I mean, in addition to kind of training physicians, I find that the other piece is empowering consumers, right? So like I feel like I'm pretty educated and I have a good sense, but then I come here and I'm like, man, I wish I had a doctor's appointment next month because now so many things have clicked and I have questions that, I don't think I would have realized.
And that's great for doctors, by the way, too, when patients kind of know what's going on, because it's like a second check and you're more involved in your care. So yeah, that's great.
Hi, good morning.
Morning.
My question is, and I'm sorry I was a little late, but my question is around when you read your doctor's notes, and I think maybe we talked about this, but when you read some of the doctor's notes and some of them are disparaging, like against you or your parents, like how do you address it? It actually happened to me and I ended up not going back to the doctor. I realize now that was not the way to go, but I was in a very fragile state.
Yeah.
So how do you address that?
Yeah, I think, wow, that's, I mean, the way I would not never disparage someone's, even things like, there's certain common like things that I guess are like triggering to oncologists. Like if a patient smokes during treatment or something, sometimes they'll disparage that. For example, I don't do that. I try not to judge anybody. But yeah, like I guess these things do make it into charts. I'm always amazed when I hear stories like that. So I'm sorry that happened to you. In that case, I think it's totally reasonable to like ask for them to maybe change. We'd always addend our notes. So I think if it is really like kind of within a realm of acceptability, kind of asking them to change it. But I think, I have a pretty high bar for reporting things, but if it's really was disparaging in a sense that you felt that it was in some way personal or very very unprofessional, then, that might warrant being escalated. But I think a good first step is just to maybe address it and ask, because we are able to addend our notes. So I know it's kind of putting a Band-Aid on something that was already done, but one would hope that the communication around the issue would help it going forward. But I'm really sorry that happened to you.
Someone else in the chat was just commenting that their surgeon is also a ThyCa survivor and that medical providers who are also survivors are so special. You give me strength and are my role models in dealing with cancer with grace and positive attitude. So thank you.
Well, that's a lot. Thank you so much. That's great.
I was saying that to Erik before we started. Like, I'm not happy to hear that you have thyroid cancer, but it is really, it's comforting when there's doctors in the room that have also been through it themselves.
Yeah, and it's interesting because like I don't always tell patients that I have the history of this. I do it in two specific scenarios. One is when I think that the patient just emotionally it would help to hear that I do understand on some level what they're going through. And the other is almost in the exact opposite situation when a patient is kind of like a little more frustrated with care or like the side effects or treatments just becoming a slog and they're saying like, well, you don't know what it's like, and they kind of need a little bit of a pep talk. So what one's a really like kind of empathetic sharing experience and one's like a pep talk experience. So those are the times I specifically will share it, but otherwise I try to make it about my patient stories, not mine. But yes, having the perspective I think is generally helped me be a better oncologist.
And I think that we will leave it there then.
Okay, well,
Thank you so
all.
much for your
Yeah.
time.